Well, thank you everyone so much for having Faye and I here with you this morning. I was going to say this evening, which is obviously my time, not yours. We're really tough to be able to join you, and we've got a bit to cover along, so we'll try and keep it moving and stick to time, and look forward to any questions in the Q&A. Before we begin, I'd just like to acknowledge the Aboriginal and Torres Strait Islander peoples here in Australia as Australia's first people and traditional custodians. So I'm coming in to join you today from the land of the Muwinina people. The Muwinina people live down in Lutruwita or Tasmania, in Australia, and I'd really like to pay my respects to their elders past and present, and extend my respects to the elders of the lands that make up our nation. Faye is sitting on the lands of the Wurendjeri and the Boonwurrung people, and in acknowledging country, it's a really important moment for us to also commit and to reaffirm our commitment to making a positive contribution to the Aboriginal and Torres Strait Islander young people and their families and community that we get to work with and to learn from, which is such a privilege. So briefly, what we'd like to cover with you today in a super fast way is we'd like to tell you a little bit about Headspace. We'd like to share with you a little bit of detail about the Headspace model and how it can help our work in trying to support the neuroaffirming practice that occurs for young people. And we'd also like to share with you some work we've been doing in trying to define good care, and again how that would relate to supporting neurodivergent people, before looking at just some of the challenges and some of the things that we've been doing to try and work in this space. I'll just say straight up that a lot of the work that we do has particularly involved young people with ADHD and autistic young people, and we recognise that the term neurodivergence is an umbrella term. It relates to a wide range of identities and experiences. So I just want to recognise that up front, and also just want to recognise that we'll probably mention this a number of times throughout the presentation, but the work we're doing is really preliminary and there's a lot more work to do. So we're certainly not coming in here under any guise that we have all the answers or that we're working really strongly in this space, but we are coming in here with a strong commitment to continue to work and to learn and to grow, and look forward to hearing all the other presentations that you're all being able to watch tonight as well, to take things away for ourselves too. So just very quickly, a little bit about Headspace. So Headspace is the National Youth Mental Health Foundation in Australia. There's some details about it here on the screen. We have about just over 170 services that are located all around Australia. Faye and I work for Headspace National. So Headspace National is set up to support the Headspace services and the other service delivery operations and aspects of Headspace. Faye and I work particularly for a team called the Clinical Practice Team, and our team is focused on supporting the clinical leaders in the services around Australia to provide effective and inclusive care to young people and family, and also to support them in the work that they do in sort of upskilling and supervising and supporting and developing their staff to do the same. And so we really share in the responsibility of ensuring that services provide evidenced and safe care in alignment to the Headspace model, which I'll talk about really briefly on the next slide. And I suppose I want to just recognise that the role that Faye and I hold is one that is a little bit complex. So the way that Headspace services around Australia operate is that we have our primary health networks who receive government funding, and they commission lead agencies to operate Headspace services. And so that means that we don't have direct governance. The other thing that over the Headspace services, so governance sits with the lead agencies. The other thing that I would note is there's enormous variance in the Headspace services that are around Australia. So we have services obviously sort of clustered around our metro regions, but we also have services that are regional and rural. And each of the services really differ in terms of the staffing profiles, the number of staff they have at the services, the makeup of their teams, the different lead agencies who who operate them and the sorts of things that they may be able to draw upon from their lead agencies. And the other thing to note is that there's real diversity in terms of the needs of the staff at each of the Headspace services, but particularly to the needs of the young people in the community that surround the service. And so knowing this, it's something that prompts Faye and I and our team to think about how we do what we do with each of those services, recognising their real strengths and their real diversities and our role within it. Headspace services adhere to what we call the Headspace model. And so the Headspace model has 10 core components, and it has 6 enabling components that describe the ways that Headspace services operate and the sorts of care that they need to provide. And it's really useful, I suppose, for us to think about, in supporting services in their want to be really neuroaffirming and neuroinclusive, we can sort of draw on aspects of the model. So I've just picked out a few of the model components here that that support the work that we do in helping to enhance neuroaffirming care. And so they include things like making sure that young people are able to access services, that services are culturally and socially welcoming and inclusive for young people. That services have a strong sort of emphasis on early intervention, enhancing things like mental health literacy and looking at assessment and identified pathways, and that services are providing appropriate care, so developmentally appropriate, culturally safe, socially inclusive, that young people are actively involved in their care and that there's family involvement. The other thing is that we services use evidence-informed practice, and that's really just around using evidence to provide best practice services. Some of the enabling components that feel particularly kind of relevant or pertinent, I suppose, in thinking about how we best support neurodivergent young people include things like the consortium. And so the consortium is a representation of local community that supports the Headspace service to identify priorities and to respond to community needs. And consortium needs to have representation from key service providers across the 4 core streams of Headspace. So they need to have members of service providers who work in the mental health space, the alcohol and other drug space, and in work and study and in physical and sex.
Well, thank you, Natasha, and thank you, everyone. It's lovely to be along today. So I'm going to just really briefly touch on some things. So just wanted to mention the Good Care Framework, which is something we thought was kind of relevant maybe to today, around what a piece of work we've been doing. It's not anything like wildly new, but really trying to, just for the Headspace context, define at a really high level, kind of as a North Star in a way for all care, like all care we deliver at Headspace. What does good care look like? And within that, it's recognizing that we've always had like a lot of resources, like heaps of written material and like training as well, and that people, the kind of higher level of what ties it all together and kind of pulling us all up out of the weeds a bit when we can get stuck in really particular questions about aspects of delivering care, was a real want to kind of say, what do we consider as good care within the Headspace framework, and what does that encompass? So I can navigate myself. Excellent. Great. So just briefly, this is a model that we've been working on at the moment. So in the middle, it's kind of, I guess, just conceptualizing that good care is made up of all of these things. So the outer circle, as Natasha touched on already, there's a little bit of overlap with the kind of Headspace model, but it's saying these are kind of practice foundations. So all aspects of care should be evidence informed, be really kind of grounded in robust governance and a positive risk culture. And within that, really kind of thinking about highlighting the risk averse practices and really not wanting to be pulled into that. And so they kind of are the foundations, and then these petals, we're kind of referring to them, and the flower are the different elements of good care, which are all really intersecting. So when we get, often in our role, we get consults from centres or questions coming back from the network about, what's Headspace's stance on a certain thing, or what would you recommend in this? So in the case of providing neuroaffirming care, it's helpful to kind of come back to this, like pulling things back to good care for any young person is about like what's evidence informed in this space, and that really positioning, Naomi, what you're saying about, you know, some people unfortunately having experiences of like autism is like an exclusion criteria, or that's not, you know, we can't provide care for these young people, that actually identity affirming care is a core expectation of all care that we deliver across Headspace services. In that context, I guess just we were thinking, Natasha and myself, just about flagging a few things that are specific to the Australian context in this space. So along with all the DSM-5 changes around diagnostic criteria and processes, there's been nationally, I think, as like in other countries, a really strong push and a real growth in advocacy driven by lived experience, which has a really powerful impact on the whole sector here in Australia. There's also only in the last, I think it was a year or two, the first Australian clinical practice guidelines for ADHD were published, which really were driving a lot of increased awareness and practice as well about the need to be, when should we be thinking about ADHD, and really that highlighting presentations that tend to get missed. And a really big one being that in 2016, the government rolled out what's called the National Disability Insurance Scheme. And it's essentially a big bucket of money that the government has put aside to provide care and support for young people, or sorry, for people across the whole lifespan living with disability. So that allows people, if they're considered eligible for the program, to access funding and individual funding packages to fund things like allied health supports to support them to thrive. And within that, in this space, autism was included as an eligible disability for funding. ADHD wasn't. And there was a little bit of a slight exception with kids under 7, currently still can be included up until 7 without a diagnosis. So there's some kids with kind of broader neurodivergence being funded currently. And I won't go into it, but there's a lot of change coming in that space. But the kind of combination of these things have been, you know, people have referred to the NDIS, that insurance scheme, as being like the only lifeboat in the ocean, because there's been, you know, such underfunding and under-resourcing of care and support for neurodivergent young people and their families for a long time. So it's ended up being that there's been a lot more uptake of that scheme particularly for families and children and young people and adults as well with autism. So some outcomes of these changes are that there's, you know, some really positive things. So we're seeing a really big improvement in really kind of understanding the many and diverse ways neurodivergence can present in the community, and also a lot more people that are really willing and trying to access care, which is really awesome to see. There's been, with that, a big increase in demand across the country and the sector generally for its assessment and support. And with that, really kind of big increases in the prevalence and the kind of rates of diagnosis, particularly for autism, ADHD, and also co-occurring presentations or ADHD. And that with it has brought some kind of a lot of concern from the government about how this funding isn't sustainable. So there's some big changes coming in that space and debate going on about, you know, where funding should come from. And it's also brought with it kind of some narratives and debate within the sector around, you know, what eligibility criteria should be used for schemes with accessing, you know, determining what kind of supports are available to neurodivergent people. It's brought with it the kind of NDIS scheme has reintroduced functioning labels for autism, which is something that is problematic. So there's been, you know, there's still quite a lot of debate going on about that. And there's been a lot of discussion and media coverage about kind of, is there overdiagnosis going on, concern about the practice and quality of assessment nationally, just being really varied. And with that, there's kind of, I think people are struggling, and that there's been some really positive changes with reducing stigma in that being neurodivergent or autistic is something that people are much more, you know, feeling able to relate to really positively and share and seek support. And in other ways, there's also been an increase in some negative narratives out there about, you know, everybody's got ADHD now, or these labels are becoming fashionable. So there's some barriers coming up in that context. And also there has been a bit of a, with the kind of introduction of new funding sources, which has been really great to see. It's also leading to people getting kind of pushed between the two systems a bit, like that's not mental health, that's disability. You know, we can't, you should access care over there and not over here, and more young people and families falling through the gaps. And with our workforce, I'm just noticing the time, I'm going to go through this really quickly. We kind of hear that reflected really, and that people are struggling with demand versus capacity. Particularly, there's just like, it's really difficult to access assessment and really costly. So how do we provide neuroaffirming care when we can't officially give a diagnosis or a thorough assessment? A lot of want for more training, resources and guidance, and kind of support and how to navigate some of those narratives around why our diagnosis is increasing, and a big need for advocacy. And I will flick over to, sorry, Natasha, I've used up most of the time, just if you really quickly want to touch back in.
Not at all, Faye. Just very quickly, I feel like it's probably preaching to the converted, but in a lot of the work that our team do is around training and consultation with services, and we've really tried to think with training about how to meet the needs of the different staff members. And so it's early, you know, it's still early days and there's still a lot more work to do, but I think one of the things we're really keen to see how impactful it may or may not be has been some training being developed by some of our colleagues who have been training early career clinicians through a graduate program, and they've been training the clinical educators who support them as well. And so it's this sort of bottom up and top down approach. We've been providing training to staff in a number of different formats. And as Faye was saying before, we really look to draw on the Headspace model and on the model of good care to centre identity affirming care as core business, and something that that any practitioner or clinician can do with any young person, regardless of diagnosis or not.
Okay, we're almost out. Yeah, so just and yeah, just kind of touching briefly that we also kind of really working to keep on centering and integrating lived and living experience through our participation groups at Headspace. So sorry, we're using acronyms. So the family reference groups and young people and First Nations young people reference groups we have, both nationally and locally. And yeah, a challenge, I guess, as well is that research and practice is moving quickly in this space, which is really innovative and exciting. And it's, yeah, we're trying to keep up with that. So I think, yeah, just trying to keep working on getting, you know, improving the training we have and increasing and reviewing some website resources. Yeah, so just acknowledging there's lots still to do. And yeah, we'll leave it there. Sorry for going a little bit over. And yeah, thank you on behalf of both of us for having us along today.
Thanks, Naomi.